The recording, ma. Okay. All right. Okay, so you can continue. Thank you.
Okay, ma. Good morning. Once again to consultants, teachers, and mentors. This morning I'll be taking the session 1, and my name is Dr. Ryan. So the question says a 60-year-old man, non-hypertensive, presented with difficulty with breathing, productive cough, paroxysmal nocturnal dyspnea, bilateral leg swelling, irregular pulse, bibasal crepitations, and tender hepatomegaly. The first sub-question is, what is the diagnosis? So in this scenario, of a 60-year-old man with a comorbid of hypertension that is presenting with classical features of difficulty in breathing, productive cough, PND, bilateral leg swelling, irregular pulse, bibasal creps, and tender hepatomegaly. One of the key diagnoses that will be running through our mind is heart failure. And in this patient, one could see it as one could hazard a guess that probably is heart failure secondary to an hypertensive heart disease, or that is precipitated by maybe non-compliance to his drug, or arrhythmias because of the irregular pulse, atrial fibrillation. So, so the diagnosis here is clearly heart failure. And by way of definition, heart failure is not a single pathological diagnosis, but a clinical syndrome that consists of cardinal symptoms, i.e. breathlessness, ankle edema, and fatigue, that may be accompanied by signs, e.g. the raised JVP, the basal crackles that was mentioned in this patient, and the peripheral edema. And it is due to structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest or during exercise. So what I'm trying to say is that basically heart failure is defined as a clinical combination of congestive signs and low output failures that is now that is corroborated when we have objective evidence of cardiac dysfunction, maybe by having some investigations like elevated BNP, or echo evidence of systolic or diastolic dysfunction, or evidence of elevated left atrial pressure. So it is basically a clinical diagnosis. So using the Framingham criteria for diagnosis of heart failure, where two major criteria, or one major criteria and two minor criteria are taken for diagnosis. This patient that we just talked about had PND, one of the major criteria, had a raised JVP, had crackles in the lung field, and that's already three major criteria. And then the patient has dyspnea on exertion with tender hepatomegaly. So we can hazard that this patient has heart failure. So the next question talks about the three imaging modalities that you will do. Okay, so my approach to answering it, imaging modalities, that's what the question says. So one of the key imaging modality to help us to assess cardiac structure and function is echocardiography, a transthoracic echocardiography 2D. And this helps us to determine the left ventricular ejection fraction. It gives us information about the dimensions of the chambers, whether there is left ventricular hypertrophy, regional wall abnormalities that could suggest underlying coronary artery disease, and also pulmonary hypertension, valvular functions, and also markers of diastolic function. Because having defined heart failure as a clinical condition, we need to corroborate it with objective evidence of cardiac dysfunction. Another imaging, cardiac imaging that can be done is cardiac magnetic resonance imaging that helps to evaluate the myocardial structure and function in patients with poor echo windows. Coronary angiography is also recommended in patients with heart failure who have angina pectoris or an angina equivalent, to help us establish diagnosis of coronary artery disease and its severity. Cardiac CT is not so much used because of, it's already the CMR has already taken its majority of its role, but it's also a cardiac imaging. So for cardiac magnetic resonance is recommended for the assessment of myocardial structure and function in those with poor echo windows, and that's a class of recommendation of 1 and level of evidence C. And same thing for CT, coronary angiography. Radionuclide imaging of the heart, like the SPECT scan, the single photo emission CT, is also an imaging of the heart, and the more advanced positron emission tomography. All this can also help us with the structure and function of the heart. Coming to the other cardiac specific investigations, we talk about the electrocardiography, which helps to reveal underlying abnormalities like atrial fibrillation, where there will be no discernible P waves, and the RR intervals will be irregular. We could also have Q waves that is telling us about an infarction going on. Also, left ventricular hypertrophy or left atrial hypertrophy or widened QRS in complete bundle branch blocks can also be seen to help us to improve our likelihood of diagnosis of heart failure and to also guide therapy. So it's said that a completely normal ECG almost exclude the diagnosis of heart failure, particularly when the patient has a systolic heart failure or is in acute heart failure. Other specific investigations that can be done also includes the chest radiograph, the posterior anterior view or the lateral view. And what we see classically, the perihilar battering shadowing as a result of alveolar edema, and Kelly B lines that talks about interstitial edema as well. Then there's cardiomegaly, the dilated prominent upper lobe veins, that's the upper lobe diversion, and pleural effusion. Another cardiac specific investigation are the natriuretic peptides. The B-type natriuretic peptide, BNP, is a peptide that is synthesized by the myocardium in response to cardiomyocyte stretch. So the atrial or ventricular wall stress, especially when there is left ventricular wall stress from volume or pressure overload, is the primary driver of BNP secretion. Now, the pro-BNP is a precursor of BNP, and it is cleaved to BNP and N-terminal pro-BNP. The N-terminal pro-BNP value is usually about, or approximately about 4 times that of BNP, and it's also elevated more in older patients and in renal failure. So a BNP that is greater than 400 to 500 picogram per mil, or NT-proBNP more than 1,000 picogram per mil, is highly suggestive of acute left heart failure in a patient with acute dyspnea. While a BNP that is less than 100 picogram per mil or NT-proBNP less than 300 pico per mil exclude left heart failure as a cause of acute dyspnea. A BNP cutoff of 35 picogram per mil or NT-proBNP cutoff of 125 picogram per mil exclude chronic HF as a cause of chronic exactional dyspnea. So the fourth question talks about the echo grading, because after we've made the diagnosis of heart failure, we now need to we've made a diagnosis clinically, so we now need to do an echo to help us differentiate the phenotypes. So the first one is the heart failure with reduced ejection fraction. And that one is in echo, when we have echo findings of left ventricular ejection fraction that is less than or equal to 40%. And then the next is the heart failure with mildly reduced ejection fraction, when the LV ejection fraction is between 41 to 49%. And then the heart failure with preserved ejection fraction, when the LV ejection fraction is 50% or more. So the fifth question talks about, let me go back to the question. List four classes of drugs with one example each that have been backed by a class 1 recommendation. So the classes of medications that have a class 1 recommendation in the management of heart failure includes the angiotensin converting enzyme inhibitors, and it is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure hospitalization and death. Also, a beta blocker is also recommended also to help reduce the risk of heart failure, hospitalization, and death. And mineralocorticoid receptor antagonist is also has a class 1 recommendation for to improve mortality. The SGL2 inhibitors, dapagliflozin or empagliflozin, are also recommended to improve mortality. And the angiotensin receptor and neprilysin inhibitor, that is sacubitril valsartan, is also recommended as a replacement for ACE inhibitors in patients with heart failure to also reduce mortality. Other pharmacological treatment indicated in these patients will, as we suspect, a loop diuretic also has a class 1 recommendation, especially when this patient presents in acutely decompensated heart failure and they have bibasal crepitations, they have beta edema, so we need to decongest them. And diuretics are also are recommended as a class 1 recommendation to help relieve signs and symptoms of congestion and improve symptoms in these patients. Angiotensin receptor blockers is also recommended in patients that cannot tolerate ACE inhibitors or ANI. For the specific drugs that are recommended in these classes, as we know, ACE inhibitors, captopril and april, lisinopril, ramipril, and their respective doses, the starting dose and then the target doses are also listed here. And these are medications that have class 1 recommendation, which means that they are recommended or indicated for use in patients with heart failure. Thank you very much.
Okay, thank you very much, Dr. Rahim, for the very lucid discussion. Please, can you help us just keep it on the question page? So while we take comments and questions from the participants. Okay. There's no hand up yet. Okay, so there's
go ahead.
Okay, ma. So there's a comment in the chat. So there's some thanks then. Thanks so much, Chief, for your presentation. I think it may be safer to say biventricular failure, since features of both sides are stated, than to just say heart failure, which may appear vague. Please, is mildly reduced the same term as mid-range ejection fraction? Thanks a lot for the presentation. Okay, Dr. Rahim.
Thank you so very much, sir, for the questions. So I'm talking about whether to say a biventricular heart failure or simply put it as heart failure. I think I understand what you're trying to say, that since the symptoms of both left and right side of the heart are present, that we can call it biventricular heart failure or congestive heart failure. You're actually quite correct, but in in the guidelines that was released, they tried to cone more on just saying heart failure rather than because there could be so many, there are so many forms, so many um, um, forms of heart failure. So yes, I don't think there's anything wrong to say biventricular or just heart failure in this scenario. So um, I don't know if there's someone can help us with more on that. So about the mildly reduced, okay. So before before the latest guideline, it used to be mid range. That is for the LV ejection fraction of 41 to 49. So that used to be mid range, but the current terminology is mildly reduced, because when we say mid range, it's kind of like, is it like just in between the um, um, reduced ejection fraction and preserved ejection fraction? But I mean, the new recommendation is to use mildly reduced. Yes, thank you.
All right, thank you, Dr. Rahim. So there's some hands up. Dr. Maduka, I think I saw your hand. I don't know if you still want to make your comments. Okay, Dr. Christian Ade.
Okay. Thank you very much. Thank you, Dr. Rahim. Excellent presentation. I just wanted to say something about the diagnosis. I mean, I think generally we have always been told that heart failure is a clinical syndrome, and if you say heart failure alone, it's not a complete diagnosis. So we need to say the cause as well as the precipitant. So in this case, I think the diagnosis should be complete. So either we say congestive cardiac failure or biventricular failure secondary to hypertensive heart disease, precipitated by most likely an arrhythmia because of that irregular pulse, either an atrial fibrillation or any of the other arrhythmias. So I think we should make the diagnosis very complete. So it's a syndrome. You need to tell us the cause. You need to tell us the precipitant. So that's what I wanted to clarify. Thank you very much. And then I think the second point I also wanted to make was that regarding the medications that are used, when you talked about the SGLT2 inhibitors, you said that they are used for heart failure with reduced ejection fraction. Yes, that is correct. But I think recently other trials have come up and they have also shown benefit in heart failure with preserved ejection fraction. So currently it is used for both heart failure with reduced ejection fraction and then heart failure with preserved ejection fraction. So I just wanted to make that extra addition. Thank you very much. Excellent presentation.
Thank you very much, sir. Thank you so very much. We mentioned at the beginning, we actually stated the full diagnosis the way you have said it. Only that I didn't put congestive or biventricular. I think that was what the person was trying to say. So at the beginning, we already mentioned that it is heart failure, most likely from hypertensive heart disease and precipitated by arrhythmias or atrial fibrillation in this case. So that SGLT2 inhibitors are also used for heart failure with preserved EF is also well taken, sir. That has also been recently added to it. Thank you so much, sir.
All right, thank you, Dr. Chris. Thank you, Dr. Ryan. Dr. Olarinwaju.
Good morning, facilitators and other colleagues. Thank you, Dr. Rahim, for this very lucid presentation. It's really educative. Mine is just to also clarify the word of congestive and biventricular failure as it was being deposited by the earlier speaker. Though at times someone may be in congested states and not, so that we won't just be using the term of congestive or biventricular. We've known that it's a clinical syndrome anyway. However, the patients may just present with both left and right failure without the lungs really being congested. And in that case, if the left and the right symptoms of right and left failure is present and there's no bibasal creep, as the case may be, in that case, we are going to just make the use of biventricular failure. But when we have both symptoms, in addition to the lungs to be congested, that's when we use congestive heart failure. In other words, it's just changing words depending on the findings from the examination and the history that is being gotten from the patients. Secondly, what I want to say, in addition to what Dr. Rahim has said, although the second question was talking about the investigation image of modern interest, and you've really backed it up with level of class of recommendation and level of evidence. And I think in addition to what we need to put forward as part of the first choice should be chest X-ray, especially in our own environment. You know, chest X-ray will also give us, they may not be specific, I will still give us general findings of heart failure, which you stipulated during the second or the third question. I think it will also be appropriate to put it forward during the second question, as the case may be. Then thirdly, in addition to what we've said, what about patients that that won't respond to ARB or ACE inhibitor, right? In terms of the drug of recommendation class 1, I think that's when isosabide hydralazine also come into play, that this can also be used to substitute. I don't know if to really stretch that it's also part of class 1 recommendation, because it's an option for those that do not actually respond or that do react to ACE inhibitor or ARB. I think that's just the little one I need to add to it. Thank you.
Thank you so much, Chief. For the hydralazine isosabide dinitrate combination, since the question asks for drugs that is backed by class 1 recommendation, that's why I did mention it, because hydralazine isosabide dinitrate has a class 2A recommendation and level of evidence is B. So it's class 2A for those that can not tolerate, or for one reason or the other, and also for it has been found to be very useful in blacks as well. So it's because of the question of class 1 level of recommendation. That's why I didn't add it to it. Thank you so much. Also, somebody also said in the chat box about ejection fraction, improving ejection fraction. Yes, so there is that subgroup as well for patients who probably started out as reduced ejection fraction, and when they started guideline directed medical therapy, and after a while their EF actually improved. So that is for those that have improving EF, but before you can improve the EF, you have to either be in the reduced or mildly reduced EF range. Thank you.
All right, thank you, Dr. Rahim. So some other comments, I think some of them have been addressed. So Dr. Cassidy talked about congestive heart failure secondary to hypertension precipitated by arrhythmia. That has been addressed. Dr. Justice asked, would it have been wrong to add chest X-ray to the 3 imaging modalities as well? I think that's what Dr. Olarinwaju also tried to say. That, I mean, which I also want to add, I think in the exam, like in listing the 3 modalities, I think chest X-ray, echo, and maybe the cardiac MR should be, at least chest X-ray should be part of the initial 3 because they said modalities that you will do. So we are definitely going to do that, especially in our setting. Okay, some thank yous, and then chest X-ray should be under imaging. Yes, said that. Thank you. There's improved. So somebody asked Dr. Blessing Azukoye, as part of your treatment, you didn't mention anticoagulants, especially as the patient has a background AF. Then some other comments regarding the terms congestive biventricular hypertensive. Okay, other comments on chest X-ray. Yes, chest X-ray. I think chest X-ray should have come earlier. Also, fissural edema could be seen on chest X-ray. Then are all beta, okay, so this is from Dr. Mushokpe. So are all beta blockers usable, and can they be used in all phenotypes of heart failure, especially in this patient? Then she also asked that furosemide does not have survival. Okay, she commented that furosemide does not have survival benefits. And then Dr. Cassidy listed the 3 imaging modalities as chest X-ray, echo, and cardiac MRI. So I think Dr. Mushokpe's comments, sorry, regarding beta blockers.
Okay, thank you very much. I think it's well taken that the chest X-ray should be part of the imaging modalities that we should mention, especially in our environment. So thank you very much, Matt. That's well noted. For beta blockers, all beta blockers. So beta blockers, let me start by first looking at it. Just break it down this way that for beta blockers, they actually contraindicated and may even actually worsen heart failure, especially in the face of acute decompensation of heart failure. Even though there are now newer trials to say that you can start them in acutely decompensated heart failure, that you just need to start low and go slow, that you start with a very low dose and you titrate it very slowly. So yes, so that's something to note about heart failure. So the 3 agents, beta blockers, that have been shown to improve survival and outcomes in heart failure are the long-acting metoprolol, that is metoprolol succinate, and is a selective beta blocker. And carvedilol also has been shown in clinical trials. Carvedilol is a non-selective beta-1 blocker and alpha blocker as well. It's also been shown has been useful, and also bisoprolol, a selective beta-1 blocker. So for metoprolol, you could start at 12.5 or 25 milligrams, and then titrate upward as tolerated by the patient per day. And then for carvedilol, you could start at 3.125 milligrams BD, and then you keep on titrating. I think the maximum dose of carvedilol is 25 milligrams BD, the target dose. For bisoprolol, you could start at 1.25 milligrams daily, and then to a maximum dose of 10 milligrams per day. So those are the beta blockers that trials backing them up as being helpful in heart failure. So furosemide.
Right, thank you, Dr. Ryan. Okay, yes, go ahead. Furosemide, yeah.
Yes, yes, ma'am. He said furosemide does not have survival benefits. Yes, that's true. But when the patient presents in acutely decompensated phase, they are breathless, with the crackles all over their chest. Some of them could even have abdominal edema, anterior wall abdominal edema, sacral edema, by bilateral pedal edema up to their thigh. So in those kind of patients, you have to decongest them so that they can to improve their symptoms. So that's what furosemide basically, the role of furosemide to help us in decongestion of the patient.
Okay, somebody asked about anticoagulation, but
Hmm.
well, Dr. Rahim, I was thinking that they asked for class 1 drugs with evidence.
Yes.
Well, what's your take on the anticoagulation, given that they mentioned the patient has an irregular pulse?
Okay, so so in this patient, the anticoagulation for the patient is an added treatment that should be acceptable for this patient as well. So I was just guided by looking at the classes of drugs that I would like to use that are backed by class 1 recommendation. So in a patient that is having heart failure, congestive heart failure, that is precipitated by atrial fibrillation, then we need to also address the precipitant. So in addressing the precipitant, prior to this latest guideline that talks about that on atrial fibrillation, that sort of like changed some things about atrial fibrillation. The former guideline, which I still remember, talks about talk about the ABC of controlling arrhythmias. And the Part A in that mnemonic talks about the anticoagulation. The B talks about the beta symptoms in these patients, in which case you give them something to control their rate or their rhythm. So either a rate control drug or a rhythm control drug can be given, and then you treat comorbidities. That is for this C. So yes, anticoagulation can be added in this particular scenario.
All right, thank you, Dr. Rahim. The two hands up. Dr. Maduka.
Okay, good morning. Good morning, teachers, senior colleagues, and everybody present. I wanted to make a comment earlier, but I was locked out, so I may risk repeating some of the things that have been said. However, I will just try to be very brief. Yes, somebody mentioned something about heart failure with improved ejection fraction. Okay, so yes, there's an entity like that, and what it simply means is that there is a left ventricular ejection fraction that is less than 40% at baseline. Okay, and then with improvement of up to 40%, or at least up to 10% increase during the first 1 month to 1 year after discharge. So that definition actually has certain numbers, attached to it. So it's not just it was reduced and then it improved. So we already know that reduced ejection fraction is less than 40. So this patient comes in with reduced ejection fraction less than 40. And then with treatment, ejection fraction improves by greater than 10%, usually within between one month to 1 year, okay, following discharge, or up to 40% improvement is also part of the definition. So that is it for that. And yes, his definition, I liked his definition, but in addition to adding an objective laboratory evidence of heart failure, which in this case, which is a BMP, okay, part of the current definition now attaches inability to perfuse the end organs in the body, or doing that with elevated intracardiac pressures. So okay, that may just be for the cardiologist, but I just wanted to chip that in. And yes, I agree that he has mentioned the beta blockers that are used, the Avidelo, which was supported by the Copernicus trial, the bisoprolol by the CBIS trial, and then the metoprolol by the Merit HF trial. Then I wanted to make a little bit of, will I say, correction in what he said, that beta blockers are contraindicated in acute heart failure. So I think that using the word contraindicated is a very strong word to use. Okay. Yes, we all know that beta blockers, they have the tendency, okay, to worsen heart failure when used in the acute setting. Okay, but it doesn't mean that it is contraindicated. Okay, so most texts will say that you should leave that decision to the specialist or act cautiously. For instance, you can have a patient in heart failure doing a heart rate of almost 200. Probably you may have added certain medications, maybe digoxin, and the rate is still high. The onus lies on the specialist to decide whether, okay, will I want to add a little bit of beta blocker to see how this patient fares? So yes, I agree that beta blockers worsen heart failure or may worsen heart failure in acute setting. But saying that it is contraindicated, it's a very strong word to use. So these are the little inputs I wanted to make. And then for the number 5, it says list 4 classes of drugs with one example each that have been backed by class 1 evidence. So this question is like an open question. It didn't seem as being directed towards the patient. Okay, so yes, the things he said are correct, and he listed 4 of them. But if we are told to manage this patient, definitely we want to talk about anticoagulation in this patient. We want to talk about giving something to improve the rhythm, as it were, because in setting of heart failure with perceived atrial fibrillation, okay, digoxin is still the choice. I think I'll bet it's class 2A evidence. So by and large, I think he did very well. Just wanted to try and clarify certain gray areas. Thank you very much.
Thank you very much, Dr. Maduka. Dr. Ide Ifeoma said that beta blockers should be avoided in flash pulmonary edema, usually caused by renal artery stenosis. Then Dr. Moshope mentioned the beta blockers, carvedilol, metoprolol, succinate, bisoprolol, and nebivolol. And the seniors HF study supports the nebivolol. Then, as was said, furosemide is supportive, does not improve mortality. All right, thank you. So I'll then hand over to our teachers and facilitators for any other comments or clarifications.
Oh, thank you so much, Dr. Temitope. Thank you. Dr. Rahim, thank you so much. That was wonderful. I must appreciate the cardiologists in the house, from Dr. Abdulaziz, Dr. Maduka. I don't know if Dr. Temitope, did I miss any other name? I appreciate all of you for your questions. I think Kasibe too. Thank Kasidi. Thank you so much for your contributions. I think you guys have said quite a lot already. Dr. Fatima, I don't know if you have any comments.
Yes, ma'am.
Fatima.
Yes, ma'am. Yeah, well done, Dr. Yusuf Rahim, for the wonderful presentation. My comments are, number 1, regarding the diagnosis. Saying heart failure is enough. You don't have to say it must not be biventricular heart failure or congestive. It depends. If the patient is congested, fine. But saying heart failure, you will not be penalized. Heart failure secondary to hypertensive heart disease precipitated by likely chest infection, because this patient was coughing, which is productive. So if you further question that the sputum is maybe brownish or greenish, that suggests infection. Or when on examination, you hear, from the question they said there is bibasal crepitation. So if it's cause crepitation, then that is in keeping with chest infection. But fine crepitations could be from just congestion in the lungs. So heart failure is secondary to hypertensive heart disease precipitated by chest infection and or arrhythmia, or complicated by arrhythmia. So arrhythmia, likely atrial fibrillation, being the commonest arrhythmia that complicates heart failure. So arrhythmia in this question could be a precipitant or a complication. So it all depends on the scenario. But in this case, it depends. Some examiners can say you can modify it. So just to have it at the back of your mind. it could be a precipitant or it could be a complication. Whatever way you say it, you can defend it if you really understand what you are doing. Then regarding the investigations, you have to mention common sense. I am not sure if there is any center in Nigeria that does cardiac MRI, but you are starting with cardiac MRI. I don't know why. Common sense occur commonly. And you have to use what you have in your front before you start thinking of MRI. Number one, ECG. More than 90% of patients coming with heart failure have an abnormal ECG. So having a normal ECG means you have to investigate more. Is this patient really having a heart failure? So having an abnormal ECG, number one, is very, very important. Then chest X-ray. That one has been mentioned by a lot of participants. Then echocardiography. So these three investigations, you can even mention coronary angio. Having hypertensive heart disease maybe for long can be complicated by ischemic heart disease. Cardiac MRI is mostly recommended when you want to make a diagnosis of cardiomyopathy, which might not be easy to diagnose on echocardiography. So cardiac MRI is the best in making the diagnosis of cardiomyopathies and other valvular heart disease. Then regarding specific investigations that they were asking, BNP should be the number one. Having a normal BNP excludes heart failure. Because if you look at the scenario, a lot of patients with other conditions can present typically like this, but having an abnormal ECG is required, elevated BNP is required to make a diagnosis of heart failure. So that is number one, regarding specific investigations. Then others, as we mentioned, coronary angio, then you can talk down of cardiac MRI if need be. Then regarding beta blockers that should be used in heart failure, usually cardioselective beta blockers like the atenolol, bisoprolol, metoprolol, Nebivolol. These are the cardioselective beta blockers that are recommended in heart failure. And saying that it's contraindicated to give beta blocker, that is a very wrong statement. There are different schools of thought. Some say you can start beta blockers depending on your patient response. If you see the patient is deteriorating or not improving, you can consider suspending it, starting low dose. But some patients, you can start them with beta blockers and you see significant improvement. So for all this medication, this class, this 4 quadruple therapy for heart failure, the 4 classes of drugs are supposed to be started all at once, but you start low and go slow. You start from low doses because benefits have been shown from studies. You give them. Then the classes of drugs, you should remember that ARNI, ACI, and ARB, they all belong to the same class 1. They belong to the same class. You can't mention ARNI, then you say number 2, ACI, number 3, ARB. No. ARNI, ACI, and ARB, you are taking off one thing. Then beta blockers, then MRAs, then SGLT2s. And SGLT2s are recommended for both HFpEF and HFrEF, evidenced by studies like DAPA-HF, EMPERO, PRESERVED, and others. So this is my little comment. And yeah, regarding the issue of heart failure with mildly reduced ejection fraction, that has been addressed by Dr. Okorafor. I don't want to be repeating things. Thank you so much.
Thank you so much, Dr. Fatima. Thank you. Thank you. I don't know if any of our teachers have any comments. Chifuki, Chitu, Remigu, Dr. Hatu is in class. Any comments? Okay. Since there are no more comments. So Dr. Ayo, once again, we appreciate your time. I was told reliably that you were reached out to as an emergency to take this question and you stood up to the task. Thank you so much. We appreciate such sacrifice and we also applaud such attitude. This is the type of attitude to encourage in this class. Thank you so much. We appreciate you. I appreciate your time. Dr. Mitapa, you can move to the next question, please.
Okay, ma. Thank you. So, Dr. Ryan, please help us stop sharing so that Dr. John can share his slide. Dr. Adibuka, okay.
Good morning.
Good morning. You're audible. Go ahead.
Can you see my slide?
Yes.
Okay, good morning. Good morning, senior colleagues. Good morning, teachers. Good morning, consultants and colleagues. So I'll be presenting on question 2. The question says, a 63-year-old man, known type 2 diabetes, hypertensive, BPH patient who was recently diagnosed with retroviral infection and was commenced on heart. He was not regular on medications. His BP was 230, 130, later on dropped to 160, 100. He's on lisinopril, nifedipine, metformin, atorvastatin, and other medications. Now the questions go like this. What are the possible causes of his dizziness? Which of the drug causes the dizziness? How will you ensure drug compliance? Which heart, what kind of drug anticipation? We just look at the patient and the comorbidity the patient is having and the questions that followed. He's 63-year-old, having type 2 diabetes, which means that he might have had the diabetes for long. He's also having hypertension, with complications the patient is likely to have, and BPH, where the patient may present with recurrent UTI and then possible urinary tract infection and obstructive uropathy. He was also diagnosed with retroviral infection and started with heart. We don't know the type of heart medication that he was on. And he's not also regular on his medication, which is also a problem. This patient is likely to be on so many drugs, looking at all his comorbidities. And the other complaint he has is the repeated dizziness and falls. Now, concerning the BP dropped from 230 to 160, which is significant, that can cause orthostatic hypotension, and the diastolic from 130 to 100, which is also significant. Even though some of the few drugs are given, look at what we have. Some of these drugs can cause dizziness. So we'll look at the answers now. Now, what are the possible causes of his dizziness? Dizziness can be grouped in so many ways. In this patient, the patient can present with pre-syncope or syncope. With the pre-syncope, the causes may be from orthostatic hypotension, as we saw the BP, dropping from 230 to 160 for systolic and diastolic from 130 to 100, which is significant. That one alone can cause repeated dizziness and falls. It may also be from autonomic dysarrhythmia or autonomic dysfunction. It's a non-diabetic. This patient may also be predisposed to Parkinson's disease because of his age and then possible recurrent strokes. So with autonomic dysarrhythmia can lead to his dizziness. He may also be having vasovagal syncope as a result of possible some other arrhythmia or even his recurrent UTI. Arrhythmia may be one of the causes of his dizziness. Maybe tachyarrhythmia, bradycardia, sick sinus syndrome. He may be having some carotid disease, which may even lead to his dizziness that he's having. Now that he's not compliant on his medications, he may also be doing overdose medications in case he forgets about his medications. The second possible cause of dizziness can be from vertigo. I know we had a presentation on BBV the last time, which may be a result of his dizziness. He may also be having dizziness from disequilibrium, most likely from Parkinsonism or the peripheral neuropathy that most likely coming from his diabetes. He may also be having cerebral disorders and other conditions because of his age. His dizziness may also be non-specific, maybe as a result of probably anxiety, depression, or sometimes alcohol dependence. So with his dizziness, these are all the causes that are likely to ensure his recurrent dizziness and then repeated falls. Now, this is how dizziness is being categorized. You can have vertigo causing his dizziness. So if it's vertigo, the BPPV we have discussed about that one, it could also be Meniere's disease. For disequilibrium Parkinson disease, I spoke about that one already. This patient is likely to have Parkinson disease. Diabetic neuropathy, strokes has a risk factor for all those ones. For the pre-syncope, we spoke about that, which is orthostatic hypotension. That can actually come from the drugs that he's taking. Parkinson and then diabetic autonomic dysfunction, we discussed about that one. The other category may be medications that the patient may be taking for neuropathy, especially the pregabalin and other medications that he may be having some spinal problems that they may put the patient on. So any of these ones can be cause of his dizziness. Now, the other question is, which of these drugs can cause dizziness, or which of the drug causes dizziness? It's on so many drugs. Some of the drugs are not actually mentioned over there, but the few that are mentioned, nifedipine, patients who are on nifedipine, about 23 to 27% of them will develop dizziness. And this patient is on nifedipine. Lisinopril about 19%, and metformin 1 to 5%. This patient may also be on drugs for his BPH, maybe finasteride, tamsulosin, and some of them are side effects are maybe the dizziness the patient is having. With the heart medication, we are not told, but dolutegravir and other medication can also give him his dizziness. This patient may also be on painkillers, may also be on other medication that may help to improve his neuropathy. And those ones can all contribute to his dizziness. So there are so many drugs that the patient is likely to be on, but the few that we have seen here, they are the ones that may cause his dizziness. Now, the other question, how will you ensure drug compliance? This patient, after diagnosis of the retroviral infection, we're also told that he's now compliant on his medications. So it is a very big issue for this particular patient. And now that the drugs are likely to 5 or more because of his comorbidities, it's going to be difficult for the patient to take all the medication. So as a doctor, you need to ensure that the drug that the patient is taking is actually being taken. And then you need to know that the patient is improving. Otherwise, the patient may not be on his medication. So the first thing you need to do therapeutic patient education. You, the doctor, the nurse, and the pharmacist, you need to talk to the patient. The patient needs to know his diagnosis. What are you diagnosing him for? Why is it take the medications, and then the complications that are likely to come from the disease itself if he refuses to take the medications, and the medication side effects. The patient needs to know all these things so that he'll be able to adjust to the taking the medication. So you need to have a written action plan for the patient. So you as a doctor, you need to talk to the patient. The nurse has to also help, and the pharmacist giving the medication to the patient needs to have a written plan so that at least the patient will be able to follow up when he gets home and might forget about how he is supposed to take the drugs. You can also use drawings. Some of the people, some of the rubbers that you are putting on some of the drugs inside, you can put drawings in it. When one morning, one evening, you can put and write it on it so that the patient will be able to know. You can even put photographs or videos to help the patient. The other option to do to ensure compliance is to stratify treatment regimen. You can give the patient once daily drugs, especially like the nifedipine. Instead of giving plain nifedipine, that will be 1 morning, 1 evening, or twice a day. You can decide to give amlodipine that will be once a day. Any drug that is possible that you can change it from twice or 3 times a day to a similar one that is once a day is to be more preferred, and the patient will be compliant on that. Then you can do combined pharmacological agents. Now we are preaching that if a patient BP is well controlled, you can give 1 or 2 drugs combined together, maybe Exforge or any other drug that has 2 or 3 antihypertensives together. That will help the patient to comply. And then you have to also tailor patient preference and lifestyle. Some of the patients are so busy that they don't even have time to take their medications. They will go home, they will go to work in the morning, maybe 6 a.m. and come back at 9 p.m. So if you give drug that will be taken once a day and then let the patient understand, it will help the patient. Then you have to also minimize treatment cost. And then you have to consider providing generics. We know that some of the drugs are very, very expensive, and now some of the generics are quite less expensive. Example is Xarelto, Rivaroxaban. We have generics that are quite less expensive. You give a drug and the person will use the whole of his savings to buy the drug. At the end of the month, the patient cannot afford it again. So if you give generics that are affordable, the patient will be able to take and then comply with the drugs. And then you need to set up reminders, maybe emails, phone calls, text messages. Some of the patients have smartphones, so you can tell them, you set alarm, 6 a.m., you are taking your medication, 6 p.m., you are taking your next medication. The alarm will remind the patient that take this medication. That will ensure that the patient takes his medication. And then early follow-up visits and then short-term treatment goals, especially if the patient is being admitted and treated, and you want to be sure the patient takes medication. Don't give the patient 1 month, 2 months to come for review when you are not even sure. So you can give a short visit. Maybe you come back in 1 week or 2 weeks. And then with that one, you ensure that the patient takes the medication. Then you even inspect the medication, see that whether the patient takes it or not. Let the patient explain to you, when I was at home, I was taking the medication this way, this way. That will help you to be sure that the patient is compliant. And the last part you have to be sure is to maximize placebo effect and minimize nocebo effect. Most of our patients have negative effect on the drugs that we are giving. Example is the fact that men believe that when they are on antihypertensives, they have low libido. So they have negative effect alone before even starting the medication. So anytime they even swallow the drug and they realize that they can't even perform again, they will think that is a drug and they will not even try to take the drug again. So these are things that you have to look out for and then talk to the patient. And when all these things are ensured, the patient will comply with the medication. So these are the strategies to ensure compliance. Now, just to look at common reason for non-adherence. As we go to the consulting room every day or to the ward to see cases, one, you need to let the patient understand what he's being treated for. So if there's a lack of understanding of why he's being treated for, why he's taking the medication, what medication he's on, the side effects of the medication, the patient may not take the medication. So you need to explain. So let the patient understand why he's in the ward, what you are treating him or her for. And then complex regimen. Don't give drugs that will take you morning, afternoon, evening, or 4 times in a day. If there's a way that you can actually make it once, twice a day, or 3 times once a day, that would be better. You need to also look at the side effects of each drug and look at the patient. If this patient also comes with dizziness already, now you go and give a drug that will cause a lot of dizziness. This patient is not likely to take the drugs. So you look at side effects of the drugs and then talk to the patient, let the patient understand. You look at cost and access. Some of our patients come all the way from some of the remote areas to access specialist care. They come because you have seen them and you have a lot of good drugs within the teaching hospital. You write the drugs for them. Maybe the first day they'll be able to afford. When they go back to their villages, it will become difficult for them to get the medications. Expensive, they travel once and come and they spend all their money, they won't come back again, and they may not be able to access the drug. So this may ensure non-adherence. Forgetfulness is also something you have to take note of. The patients, some of mental disorders, you have to talk to them and the relatives to help you. Fear or beliefs, because there are a lot of beliefs that are going on right now. That some of the drugs can make you die. Some of the drugs can affect your heart. It can affect so many parts of your body. Can destroy your kidneys. So you have to talk to the patient, let them know why they are taking the drugs. Lack of symptoms improvement, mental health factors, language and cultural barriers. There are some people when they come and then you won't even give them injection. Especially those who come with some blisters or whatever you are going to give them, they won't take it. And lack of social support. If your social support is not very good, the patient may not be able to take the medications. Now, just a positive note on medication adherence. If the patient is able to adhere to all the medications, There may be improved treatment efficacy. There will be reduced hospitalization and emergency room visits, because all the time the patient is on medications, is improving, and the patient will do better. And then it will help in better disease management, whichever disease the patient has, especially our patient that has a lot of comorbidities. It also there's prevention of treatment failures. If the patient is taking the medications regularly, just like the heart medications, there won't be any failure in the treatment. It also enhances quality of life, cost savings. You don't need to be admitted in the hospital so many times because of non-compliance. So if you are able to take the medications, it will help to save cost. And then patient empowerment. As a patient know that when I take these drugs, I'll do better and take the medication. So that is how we do to improve or ensure adherence. Now, the other question is, with heart, what kind of drug anticipation are you anticipating? Now, for heart, which is the highly active antiretroviral therapy or treatment, provides effective treatment option for treatment naive and treatment experienced patients. There are so many classes that we have. These include nucleoside reverse transcriptase inhibitors, where you can see the nucleoside and nucleotide. And then we have the non-nucleoside reverse transcriptase inhibitors. We have the protease inhibitors. We have the integrase inhibitors, fusin inhibitors. Then we have the chemokine receptor antagonists, so CCR5. Then we even have the CSR4 inhibitors that are also there. Then we have the entry inhibitors. Each class targets a different step in the viral life cycle as the virus infects CD4 lymphocyte on target cells or other target cells. Now, the use of this agent in clinical practice is largely indicated by their ease or complex of use. So you need to look at that one. You have to also consider the side effects profile of each drug. Then you have to also consider efficacy based on clinical evidence before you give the patient. And then you have to also consider the guidelines that are being used, especially in our setting, WHO guidelines, because some of the drugs that they are giving are programmed drugs. And if you don't follow the WHO guidelines, at the end of the day, you may not get the drug to treat the patients for those with the retroviral infection. Then we have clinical preference. You need to select a drug that is quite effective and able to treat the patient. Now, these are the few drugs that we have. We can have the nucleoside reverse transcriptase. The common ones we use is the lamivudine, abacavir, and then tracitabine. With the nucleotide reverse transcriptase, we have the tenofovir, which is the tenofovir, disoprostol fumarate, and then tenofovir alafenamide, depending on the comorbidity, whether there's bone disease, renal impairment, and other complications. With the non-nucleoside reverse transcriptase, the common ones, efavirenz, and then nevirapine can also be used. The ones that we are using more now with the backbone of the nucleotide inhibitors is the integrase inhibitors. And what we have in our system is the dolutegravir. And the cabotegravir is also there. Maybe there's a slide I'll talk more about the cabotegravir. The PIs are used usually in children and other when there's resistance some of the drugs, leponavir, ritonavir, and the other ones. You may come across the fusin inhibitors, efavirenz, maybe CCR5 entry inhibitors, marovac, and then maybe the other ones are also called the post-attachment inhibitors, in case you come across those ones in MCQs. Now,
Dr. Adiboka.
Yes.
You still answer your questions. You spent more than 20 minutes already. It's past 8.
Oh, okay, so I'm almost done. So you just need to consider all this. Yeah. You just consider all this one when you are choosing a drug, maybe resistance and affordability. And these are the medications combination that is available: tenofovir, lamivudine, and dolutegravir. The other ones are there. These are other combinations that you may need to come across, or you may come across if you want to take a regimen. And these are some of the guidelines that you will see. The last slide is the cabotegravir, which is used for possible people who have suppressed viral load, and then they need to be on injectable. So every month the patient comes for injection. And then in the US, it's also approved for pre-exposure prophylaxis. So some of these drugs are quite good, just that sometimes they may not be available in our environment. Thank you very much. Comments and questions, these are my references.
Thank you very much, Dr. John. Please, can you help us put it on the question while go through the comments? Okay, so the next slide, please. Okay, thank you. So thank you very much, Dr. John. It's quite very detailed. Dr. Ide Ifeoma says, thank you, Chief. Adherence can be broadly discussed using these headings. So 1, therapeutic education of patients. 2, maintaining contact with the patient. 3, keep care inexpensive and simple. 4, prescribe according to pharmacologic principles. 5, others. So I think that is quite similar to what's to this your slide. It has everything. So Dr. Cassidy says, thanks for the presentation. Dizziness can also be caused by heart, especially efavirenz in 50 to 60% of cases. Okay. So Dr. Kristen Ade is asking that, please, what drug is Avlos?
I didn't come across, I looked for it. I think I even kept the question on the page. I looked for it. There were so many drugs I couldn't even get to know. So I didn't want to go and put a drug that we're not even sure. So I even asked Chief Christabel about it. We didn't look for it. When you enter into the system, you won't see it. So I think there was a mistake in the recall. So that's why I didn't write anything on it.
Okay, thank you very much. Dr. Maduka, Chief, your hand. I don't know if it's a new hand.
Thank you very much for the presentation. I just needed a clarification for the question number 4. What is HAT? What kind of drug anticipation are you anticipating? So, like, if you could kindly throw more light on that. As in, I just want to understand that question, anticipation, or is it a typographical error or something? Thank you.
So I was thinking it's more of a typographical error, because if they say HAT, what is HAT? What anticipation are you what drug anticipation are you anticipating? They didn't tell us whether the patient has renal failure or the patient has other issues. If the patient had renal failure, we would have looked at drugs that are contraindicated in renal failure, so that we'll be able to pick those drugs that are quite suitable for this patient. But the question was just opened. That's why I decided to bring all these ones out for us to look at.
Okay, thank you very much, Dr. John. If I come in there, so I think in perspective what they describe about these patients, especially the issues with compliance. And so this question that we've had, what kind of drug, maybe there's a typographical error, but I'm thinking, are we anticipating there may be some challenges with compliance as well? Or is it drug interaction? Because usually when it comes to heart and patients with other comorbidities, we have to look at the interactions. Maybe that could also be what was being asked for that question.
Yeah, I think that may be true. Looking at the patient, he has he's on atorvastatin, meaning that he has dyslipidemia too. So if you are going to select maybe the PIs, it will even worsen his dyslipidemia. So I think it's something that we have to consider in choosing the drugs for the patient. And they stated in the question too that the patient is non-compliant on his medication. So we have to look for a drug that is combined. Maybe instead of giving multiple heart drugs, we give a drug that is a combination drug that the patient can take once a day. That probably will help the patient.
Yes,
Thank you,
Chief. Yes, thank you. So Dr. Geoffrey says Avlox is the trade name for moxifloxacin. So maybe the antibiotic. Yes.
Okay.
All right, thank you very much. Thank you to the contributors. I'll hand over to our facilitators. Chief Christabel.
We spent quite a lot of time. We have to close the class now. Dr. Gerard kept saying there were no typographical error. It was how it was in the exam. That was how it was put out there. So I think the last question, I think the one was a fair attempt. What I'm trying to tell you is that based on all you've been told about this patient, what type of heart would you give this type of patient? Do you understand? So every question, they need to think outside of the box. Everything is not typographical error. Sometimes I think when I went for my own exam, the suspect. Okay.